Hi everyone, welcome back to the channel. Today we'll discuss another common presentation in OPD, which is headache. Before starting the discussion, I am thankful to each and every one of you for giving a very good response to this OPD series. Also, a very happy new year to you and your family. If you wish to revise Harrison with the help of systematic revision videos and chapter-wise test, you can check Internal Medicine Revision Series course on MediLectures app, and currently there is additional 50% discount if you use the coupon code New Year. Starting with the lecture, headache is one of the commonest patient presentation in medicine as well as neurology OPD. Now, International Headache Society has classified headache into primary and secondary. Primary headache disorders are those in which headache and its associated features are disorder in itself, whereas secondary headache are those which are caused by exogenous disorders. The most common type of primary headache is tension type headache, which is seen in 69% of population suffering from headache. Second most common is migraine, which is around 16%. Then some rare forms include idiopathic stabbing headache, exertional headache, exercise induced headache, and cluster headache, which is a part of trigeminal autonomic cephalgia, is very rare, and we will see these separately. When we consider secondary headache, it can present with red flag symptoms, which we will discuss in detail in the approach slide. The secondary causes of headache includes most commonly systemic infection. Now, common illnesses like viral infection, malaria, enteric fever, dengue, all can present with headache. So, systemic infection is the most common cause of secondary headache. Then we have head injury, vascular disorders, subarachnoid hemorrhage, brain tumors can have presentation with headache. Some other causes include infections like meningitis, encephalitis, and autoimmune diseases like temporal arteritis. So these are the various causes of secondary headache. Now, a separate lecture on headache is available on this channel, which you can refer to for understanding the mechanism of headache, what all are the pain sensitive structures in cranium, what all are the neurotransmitters involved in various types of primary headache, etc. We will be keeping this lecture short and we will see only the important points which will help us to approach the patient in OPD. Now, headache is one such common complaint in which you can identify the etiology by taking a proper history alone. So, history taking is very important in these patients. So, we'll ask about the onset and duration, whether the headache is sudden or gradual in onset. Sudden onset headache can be seen with vascular disorders, especially subarachnoid hemorrhage. Then headache is acute or chronic. If the headache is lasting for more than 15 days per month for 3 months, it is termed as chronic headache. Now, what is the location of headache, whether it is unilateral or bilateral? Migraine is typically unilateral. What is the location in sense that it is frontal predominant, temporal or occipital? So, frontal sinusitis can lead to frontal headache, temporal arteritis, temporal headache, and hypertension headache is typically in the back region, typically occipital. What is the quality? Throbbing headache can be seen in migraine, then pulsating headache, stabbing headache, or dull headache, which can be seen with tension type headache. What is the intensity? We'll ask the patient to intensify his headache, whether it is mild, moderate or severe. Also, if the patient is not able to intensify in mild, moderate, severe, we can ask to score the headache from 0 to 10. Pattern and frequency is important, whether the headache is episodic or continuous, daily, weekly. What are the associated symptoms? So, migraine is typically associated with nausea, vomiting, photophobia, phonophobia, aura. Neck stiffness can be seen with meningitis. Fever can be seen with secondary headache of systemic infections. Then we will also ask the patient about any neurological deficit, if any. Triggers include stress, lack of sleep, certain foods, physical activity, medications, etc. Past medical history is very important. Whether the patient is already a known case of headache like migraine, whether there is any history of trauma, is the patient taking any antihypertensives and is missing the doses, any refractive error or chronic sinusitis. Family history, migraine runs in families, therefore we have to ask for the family history. Medication history include analgesic overuse, which can lead to medication overuse headache, oral contraceptive pills, especially these young patients who are on OCPs are at increased risk of cortical venous thrombosis, cerebral venous thrombosis, which can also present with nausea, vomiting, and headache. Lifestyle factors are very important, including diet, decreased sleep, increased caffeine intake, smoking, alcohol, stress levels. All these are associated with headache. So all these points are very important in history taking in a patient of headache. Kindly make it a habit to take at least this much history in all the patient. Sometimes what happens is we waste our time doing unnecessary investigations and patient is already a diagnosed case, but we didn't ask the past medical history and previous records of the patient. Now, if the history is suggestive of a particular cause, we'll direct our examination accordingly. So we'll check the vitals of the patient, including blood pressure and temperature, to rule out hypertension, to rule out fever, which can be associated with headache. Then we'll also examine the head and neck of the patient. We'll see whether there is scalp tenderness, which can be present in temporal arteritis, any sinus tenderness is present, neck stiffness, etc. Relevant neurological examination includes mental status examination, associated cranial nerve dysfunction, any motor deficit, sensory dysfunction, reflexes, and coordination. Now, asking and looking for the red flag symptoms and signs is very important, as these can help us to rule out the secondary causes. So what are these red flag signs and symptoms? So firstly, if the patient is having sudden severe headache, he is saying that the headache is worst headache of his life, it is suggestive of subarachnoid hemorrhage. It is also known as thunderclap headache. If headache is new onset after 55 years of age, always consider a possibility of tumor or temporal arteritis. Then presence of fever, neck rigidity, altered mental sensorium, meningitis and meningoencephalitis. Progressive worsening over the years or months, then also we can consider tumors, mass lesions leading to raised intracranial pressure. Focal neurological deficits will be present with stroke and mass lesions. Then if the headache is induced by bending, lifting or coughing, we'll suspect vascular causes. If there is associated visual disturbance, we have to rule out optic neuritis. So optic neuritis in both multiple sclerosis and NMO spectrum disorder can present with headache. Then we have to rule out ophthalmological disorders like glaucoma. We have to also rule out refractive errors. For this, we'll send the patient to opthal department. Local tenderness can be present with temporal arteritis. Now let's see what should be the stepwise approach to rule out the secondary causes, and finally how to differentiate between various primary headaches. So first, with the help of history and examination, we will try to rule out common conditions leading to headache like undiagnosed hypertension, refractive errors, non-compliance to spectacles, stress, insomnia, etc. After this, we will try to rule out as many causes of secondary headache by asking the history related to infection, any history of trauma, stroke. We will ask all the red flag symptoms, signs, etc. Moving forward, we are left with primary headache disorders. So first, we will rule out trigeminal autonomic cephalgias, as these are very rare. So features suggestive of trigeminal autonomic cephalgias include cranial autonomic symptoms like conjunctival injection, lacrimation, nasal congestion, oral fullness, and rhinorrhea. Now these TACs include 4 entities which are cluster headache, Song-Tensuna, paroxysmal hemicrania, and hemicrania continua, which we will discuss in brief in the coming slides. After we rule out TACs, we are finally left with tension type headache and migraine. Both of them are easy to differentiate. In TTH, a stress factor is usually present. It presents with bilateral, tight, band-like sensation and discomfort, and it has slowly fluctuating severity, and the severity is mild. On the other hand, migraine is a unilateral, throbbing type of pain with moderate to severe intensity, and is associated with symptoms like nausea, vomiting, photophobia, and phonophobia. Now, although TTH is much more common than migraine, but in hospital settings, we often see more migraine patients as TTH pain is not so severe and patients usually self-medicate and get relieved at home. So in this way, we have seen in detail the approach to a patient with headache in OPD. Now let's see few important points about primary headache disorders. So starting with migraine, diagnosis of migraine is done if the patient is presenting with repeated attacks of headache lasting for 4 to 72 hours with a normal physical examination. There is no other reasonable cause for headache and at least two of the following features, which is unilateral pain, throbbing character, aggravation by movement, and moderate to severe intensity, plus at least one of the following. Either nausea or vomiting should be present, or photophobia and phonophobia must be present. When we consider the treatment of acute attack of migraine, so mild to moderate attack can be treated by simple analgesics like paracetamol or NSAIDs. If the attack is moderate to severe, we'll see whether the patient is having vomiting or not. So if no vomiting or severe nausea is present, then we can use oral triptans with naproxen combination. A common preparation is available, 85 mg sumatriptan along with 500 mg of naproxen is available. Then if the patient is having severe vomiting or nausea, we will admit the patient and start on subcutaneous triptans like sumatriptan 6 mg with IV antiemetics like ondansetron, which can be given in 4 mg dose, or metoclopramide in 10 mg dose. For prophylaxis, we need to know the indications. What are the indications of prophylaxis? So indications include if the patient is having chronic migraine, significant disability and diminished quality of life, if there is contraindication or any serious adverse effect of acute therapies, and the risk of medication overuse headache. So all these are the indications to start the prophylactic treatment for migraine. So what all drugs can be used for prophylaxis? Most commonly we use beta blockers including propanol, which can be given in a dose of 40 to 160 mg per day divided in 3 doses. We can also use metoprolol in the dose of 50 to 200 mg in divided doses. We can use a calcium channel blocker, which is flunarizine, in a dose of 5 to 10 mg OD. We can use tricyclic antidepressants like amitriptyline, which is typically used in a dose of 10 to 25 mg at bedtime. And finally, anticonvulsants like valproate and topiramate. So valproate is used in higher doses of 800 to 1200 mg per day, and dose of topiramate is 25 to 200 mg per day. Now, while prescribing these prophylactic drugs, it is important to explain your patient that drugs used for prophylaxis must be taken daily, and there is a lag of at least 2 to 12 weeks before an effect is seen. Once effective stabilization is achieved, the drug is further continued for 6 months and then can be slowly tapered to assess the continued need. Coming on to tension type headache, it is described as a chronic head pain syndrome characterized by bilateral tight band-like discomfort. It is also known as featureless because it lacks the characteristic features of migraine like nausea, vomiting, photophobia, phonophobia, and aura. Now this TTH can again be episodic or chronic. So chronic is one, be it migraine or TTH or any other headache, if it is present for 15 days in a month for 3 months. Now the name TTH implies that pain is a product of nervous tension, but there is no clear evidence for tension as an etiology. What is the treatment? So it can be treated with simple analgesics such as PCM, aspirin or other NSAIDs. Behavioral approaches like relaxation can be effective. For chronic TTH, amitriptyline in a dose of 10 to 25 mg per day is the only proven therapy. Finally, coming on to TACs. So TACs include cluster headache, SUNCT and SUNA. So what is this SUNCT and SUNA? Short lasting unilateral neuralgiform headache attacks with conjunctival tearing or autonomic symptoms. Then we have hemicrania continua and paroxysmal hemicrania. I forgot to tell, once we suspect the diagnosis of TACs, the patient has to be refer to neurology department. It is not to be managed in medicine OPD. Then cluster headache, the typical attack duration is 15 to 180 minutes. Sunkt and Suna, these are very short lasting, only for 5 to 250 seconds. Paroxysmal hemicrania is 2 to 45 minutes, and hemicrania continua, as the name suggests, is continuous. So all these TACs are characterized by short lasting attacks of headache along with cranial autonomic symptoms which we have discussed, like oral fullness, lacrimatial, nasal stuffiness, etc. Also, there is severe pain occurring more than once a day. So once we diagnose TAC, patient is referred, and for more details on individual type of TACs, you can check out the headache lecture on this channel. So this is all about today's presentation. Thank you so much.